Hello friends, today we'll talk about two major category of drugs which are used in GERD and or peptic or duodenal ulcer. So let's start with the proton pump inhibitors first. The As the name suggests, they are proton pump inhibitors. Proton pump, which is also known as the H plus K plus ATPase pump, which is present in the parietal cells of the stomach and which is responsible for the acid secretion. So inhibition of the proton pump will produces the negative effect on the acid secretion, which will help us to relieve the GERD symptoms and heal the ulcers. The major proton pump inhibitors are the esomeprazole, rabeprazole, omeprazole, lansoprazole, dexlansoprazole, and pantoprazole. The usual doses of the esomeprazole, rabeprazole, and omeprazole, they are 20 mg. Lansoprazole and dexlansoprazole, they are 30 mg. And pantoprazole is 40 mg. All the proton pump inhibitors are taken once a day. In severe condition, where if the effects of these all proton pump inhibitors, if they are inadequate, then for a shorter duration of time, the doses of proton pump inhibitors can be doubled. General duration for the treatment for duodenal ulcer it is around 4 weeks and for peptic ulcer is around 8 weeks. While in the Barret's esophagitis, where the PPI is taken for whole lifetime, all proton pump inhibitors must be taken 30 to 60 minutes before the meal. But only dexlansoprazole is the drug from the PPI which can be taken with or without meal. Another important thing is all proton pump inhibitors are equally effective. So in case of inadequate effect, the switching the proton pump inhibitors will not be an effective choice. And also in this case, in the addition of if the addition of H2 receptor antagonist along with the PPI is not a good choice, because the H2 receptor antagonist will inhibit the activation of proton pump inhibitors. So they must be taken at a different time. Generally, H2 receptor antagonists, they are more effective in the nocturnal symptoms and so preferred at a night time or at a bad time, while the proton pump inhibitors are taken in the early in the morning. If we talk about the important drug-drug interaction, then the omeprazole and esomeprazole, they are the potent CYP2C19 inhibitors. Yep, and has the highest interaction with the clopidogrel. See, clopidogrel is a prodrug, and the activation of clopidogrel, it requires the acting of CYP2C19 enzyme. So the omeprazole and esomeprazole, they will block the conversion of clopidogrel into its active form and hence reduces the effect of clopidogrel and increases the risk of clotting. So this omeprazole and esomeprazole are not a good choice in patients who are taking the clopidogrel. In that case, the pantoprazole, which is having the least effect on CYP2C19 enzyme and is a good choice of drug if the patient is taking the clopidogrel. The rabeprazole is also another preferable option because the pantoprazole and rabeprazole has the least drug-drug interaction. Proton pump inhibitors, they cannot be used as needed because they have the delayed onset. In such case, the H2 receptor antagonists or antacids are the best choice. For example, if any patient comes to the pharmacy uh, with the hyperacidity because of high meal, and it's not the regular case or routine case for the patient, so in this case the PPI is not a good choice. In this case, the patient is suggested to take the H2 receptor antagonist or antacids. So H2 receptor antagonist or antacids are preferable over PPI if it is to be used for PRN or as needed case. The common adverse effects of PPI are the increased risk of fractures. If the patient is on a long-term PPI, then calcium or vitamin D supplementation is suggested to reduce the risk of fractures. The another adverse effects like increase the risk of pneumonia, then Clostridium difficile, that is C. difficile induced diarrhea, and decreases the absorption of vitamin B12. So these are the few common side effects of the PPI. If PPI stopped all of a sudden after a few weeks of therapy, then the risk of rebound hypersecretion or rebound hyperacidity may occur in 2 to 4 weeks. So in this case, the tapering of therapy is required. In the tapering, the patient can be given with the lowest effective dose for few weeks, or the alternate day regimen of the PPI can be used. So this is all about the PPI. Now we'll discuss about the H2 receptor antagonist. The H2 receptor antagonist, as the name suggests, they are the blockers of histamine H2 receptor, which is present on the gastric parietal cells and reduces the acid secretion. So they are the blocker of H2 receptors, which is present on the gastric parietal cells, and this H2 receptors has the role in the acid secretion. H2 receptors antagonists are not a good choice for NSAID-induced ulcer. So in this case, where the ulcer is induced by the NSAID, then misoprostol, which is a prostaglandin analog, or the proton pump inhibitors are the preferable drugs in this case. H2 receptor antagonists can be used as needed or as PRN for the meal-related hyperacidity. But if they are being used for less than 3 times a week, then in that case the H2 receptor antagonists are a good choice. But if they are used to for a longer period, then the PPI would be a better choice. Ranitidine may be a preferred H2 receptor antagonist. See, there are many drugs in the H2 receptor antagonists like cimetidine, ranitidine, famotidine, nizatidine. But the ranitidine is a preferable because it has comparable safety with the efficacy and has the lower cost. Cimetidine is a potent CYP inhibitor of certain CYP enzymes like CYP1A2, CYP2D6, CYP2C9, CYP2C19, CYP2E1, and CYP3A4. So it has a lot of drug-drug interaction. While ranitidine has minor effect on the CYP450, while nizatidine and famotidine, it has a negligible effect. So in that case, the famotidine can be used. If H2 receptor antagonist used for a longer period, longer than the 7 days, then it may produce the tachyphylaxis. Now this tachyphylaxis means what? Tachyphylaxis means the rapidly decrease in the effect of therapy. So whatever effect you got in a first week of therapy, if it is used for the next week, second another week, then the effect may be reduced. So that is called as the tachyphylaxis. So for a longer duration of therapy, the PPI are the best choice. In that case, the H2 receptors are not a good choice. The rebound hypersecretion may occur, same like the PPI. If they are used for more than few weeks, then rebound hypersecretion or rebound hyperacidity may occur in 2 to 4 weeks. So sudden withdrawal of H2 receptor antagonist is not suggested. You need the tapering. Tapering is required in this case. All the antacids, they reduces the effect of H2 receptor antagonist except famotidine. So if you need the combination of the antacids and H2 receptor antagonist, then only famotidine can be combined with the antacids. So friends, these are few information about PPI and H2 receptor antagonist from my side. If you have any query, then please write to us. We are seeking your valuable feedback. Our email ID is conjuspharmacologyconcept@gmail.com. Thank you for watching our video. If you like to see the more video, then please subscribe us. Have a nice day.